Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Caustic ingestions are a critical concern in medicine due to their potential for severe, life-threatening injuries and significant long-term consequences. A caustic, also known as a corrosive, is any substance that can chemically destroy tissue upon direct contact with mucosal surfaces. These agents are commonly found in both homes and industrial settings, leading to tens of thousands of exposures annually in the United States alone. The clinical manifestations of caustic ingestions vary widely, from no symptoms to acute emergencies, requiring immediate diagnosis, careful management, and continuous monitoring. Effective management of caustic ingestion requires a comprehensive multidisciplinary approach, considering the complex interplay of diverse origins, physicochemical properties, and the progressive phases of tissue damage and healing. To accomplish this, the following objectives have been designed to create the necessary knowledge. By the end of this session, you will be able to define caustic agents and differentiate their primary mechanisms of tissue injury, specifically liquefaction versus coagulation necrosis, induced by alkalis and acids respectively. You will also be able to identify key household and industrial sources of caustic substances and the physicochemical factors, such as concentration, pH, physical state, and duration of contact that influence the severity of ingestion injury. Furthermore, you will be able to describe the distinct phases of tissue damage and healing following caustic ingestion, including the critical period of low tensile strength and the progression to stricture formation. You will learn to recognize the immediate clinical manifestations of caustic ingestion, particularly signs of acute airway compromise like stridor and hoarseness, and understand the unreliability of initial symptoms in predicting the full extent of internal injury. The session will also cover outlining the essential components of initial diagnostic evaluation, including comprehensive history taking, targeted physical examination, and the utility of early laboratory studies to assess systemic impact. You will assess the utility and limitations of imaging modalities, especially contrast-enhanced computed tomography scans, for detecting complications like perforation and visualizing structures beyond endoscopic reach in severe caustic ingestions. Esophagogastroduodenoscopy is identified as the diagnostic gold standard for evaluating caustic injuries, and you will learn its optimal timing, typically 12 to 24 hours post-ingestion, its key indications, and the prognostic significance of the Zarger classification for grading injury. Finally, you will prioritize immediate emergency management, focusing on airway protection and hemodynamic stabilization, and list contraindicated interventions for gastrointestinal decontamination, such as induced emesis or neutralization. The session will discuss the evidence-based considerations for pharmacological interventions, such as the debated role of corticosteroids for grade 2 esophageal burns, and identify clear indications for emergency surgical intervention in cases of severe necrosis or perforation. You will also learn to explain the critical aspects of long-term management for caustic ingestion survivors, including the treatment of strictures such as endoscopic dilation and the necessity of lifelong surveillance for esophageal squamous cell carcinoma. A caustic, also known as a corrosive, is any substance that can chemically destroy tissue upon direct contact with mucosal surfaces. While often classically categorized as strong acids or alkalis, the definition extends to other chemicals that possess similar injurious properties. The term corrosive is frequently used interchangeably with caustic, although corrosion implies a mechanical degradation that may not always apply to caustics. Key aspects of the definition and classification of caustics include proton donors, which are acids. These substances dissociate into conjugate bases and free hydrogen ions in solution. They typically cause significant injury when the pH is below 3. The characteristic injury pattern from acids is coagulation necrosis, where epithelial cells are desiccated, forming an eschar that is theoretically thought to limit further penetration into underlying tissues. Examples include hydrochloric acid and sulfuric acid. Common household acids can be found in toilet bowl cleaners, swimming pool cleaners, rust removers, and battery fluid. Acid ingestions may also lead to skip lesions where discontinuous areas of damage occur. Alkalis, also known as proton acceptors, are substances that lead to the creation of conjugate acids and free hydroxide ions. Significant injury from alkalis typically occurs when the pH of the substance exceeds 11. These substances cause liquefaction necrosis, a process that involves the saponification of fats and disruption of proteins. This allows the alkali to penetrate deeper into tissues, a characteristic that differentiates alkali burns from acid burns. Common examples of alkalis include lye, which is composed of sodium hydroxide and potassium hydroxide and can be found in drain cleaners and hair relaxers. Another common alkali is ammonia, also known as ammonium hydroxide, which is a component of many cleaning products. Beyond traditional acids and alkalis, other chemicals can induce similar tissue damage. These include phenol, formaldehyde, iodine, and concentrated hydrogen peroxide. Additional caustic agents are Clinitest tablets and creosote. Ingredients found in electric dishwasher detergent and laundry detergent pods, LDPs, can cause severe burns and strictures. These are associated with a higher incidence of toxicity, including central nervous system depression and respiratory compromise. Zinc chloride ZnCl2 and mercuric chloride HgCl2 are noteworthy for their potential to cause severe systemic toxicity due to cationic metal injury, in addition to local caustic effects. Other agents to consider are oxidizing agents, for example, potassium permanganate, desiccants, vesicants, for example, mustard gas, and protoplasmic poisons, for example, hydrofluoric acid. The severity of injuries resulting from caustic exposure is not solely dependent on the type of agent, but is also significantly influenced by several characteristics related to its source and form. First, the concentration and pH of the substance are crucial. Generally, substances with a lower pH, less than 3, and a higher pH greater than 11, cause more extensive injury. However, the titratable acid/alkaline reserve, TAR, is considered a more accurate predictor of tissue damage potential than pH alone. This is particularly true for substances like phenol and zinc chloride, which have a near-neutral pH but a high TAR. Second, the volume and quantity ingested play a significant role. Larger volumes, especially in intentional ingestions, correlate with more severe and extensive injuries, often affecting the stomach and duodenum. Third, the physical state of the substance, liquid, solid, or gel, influences the injury pattern. Liquids tend to pass rapidly through the oropharynx, causing less injury there, but more extensive burns in the esophagus and stomach due to wider distribution. In contrast, crystals and solid particles can have prolonged tissue adherence, leading to more severe injury to the mouth and pharynx, although they are often spit out sooner due to immediate pain. Gel packs and pods, such as laundry detergent pods, represent concentrated forms that result in significant caustic injury due to their high concentration and increased tissue contact time. Fourth, viscosity affects how the agent moves through the body. Less viscous acids may pass quickly into the stomach, potentially sparing the esophagus somewhat compared to more viscous agents. Finally, the duration of contact directly correlates with increased tissue damage. The presence of food in the stomach can also influence the distribution and neutralization of the caustic agent. Caustic substances are common in homes and workplaces, causing tens of thousands of exposures each year in the United States. These substances can be grouped by their chemical type and typical uses. Household products are the most frequent cause of accidental ingestions, especially in children and the elderly. This often happens because they are improperly stored in other containers, such as jars or soda bottles. Drain cleaners are a prime example. Highly concentrated forms of alkali, like lye, sodium hydroxide, or potassium hydroxide, are often found in liquid and crystal drain cleaners. Liquid formulations can have concentrations as high as 30% potassium hydroxide or 93% sulfuric acid, while crystal drain cleaners can contain up to 74% sodium hydroxide. Oven cleaners frequently contain sodium hydroxide, for instance, for percent to 6% in products like Easy Off Heavy Duty Oven Cleaner. Hair relaxer creams also contain sodium hydroxide, with a pH ranging from 11.2 to 11.9, though injuries from ingesting them are typically mild. Ammonia, ammonium hydroxide, is a common alkaline corrosive found in toilet bowl cleaners, metal cleaners, and glass cleaners. Household concentrations typically range from 3% to 10%, but solutions with 28% ammonia have been reported to cause strictures. Detergents, including household laundry powders, dishwasher detergents, and especially laundry detergent pods, contain silicates, carbonates, and phosphates. These ingredients can induce caustic burns and strictures. Laundry detergent pods are associated with a higher incidence of toxicity due to their concentrated form and increased tissue contact time. Cationic detergents, when present in concentrations greater than 7.5%, can cause severe burns. Toilet bowl cleaners often contain strong acids like hydrochloric acid, with concentrations reaching up to 26%, or phosphoric acid. Rust removers may also contain hydrochloric acid at 10%, hydrofluoric acid at 2.5% to 3%, sodium hydroxide at 50% to 75%, or phosphoric acid at 25% to 30%. Household bleach typically contains dilute sodium hypochlorite at 3% to 5%, which rarely causes significant injury if ingested. However, industrial-strength bleach has much higher concentrations and is more likely to lead to esophageal necrosis. While not traditionally considered caustics, certain medication pills can cause pill esophagitis if they adhere to the esophageal lining for prolonged periods, especially if taken lying down or without water. Examples include doxycycline, tetracycline, potassium chloride, antimalarials, and aspirin. Potassium chloride is particularly dangerous and can potentially cause esophageal perforation. Agricultural and industrial cleaners, such as dairy pipeline cleaners, contain liquid sodium hydroxide and potassium hydroxide in concentrations of 8% to 25%. Swimming pool chemicals often contain concentrated acids like muriatic acid, hydrochloric acid at 31%, or sulfuric acid. Substances like sulfuric acid, hydrochloric acid, sodium hydroxide, ammonium hydroxide, and hydrous ammonia and metallic lithium are used in the illicit production of methamphetamine, leading to severe caustic injuries if ingested. Specialized caustics include phenol, formaldehyde, iodine, concentrated hydrogen peroxide greater than 30%, zinc chloride, mercuric chloride, and button batteries. Both phenol and formaldehyde are general protoplasmic poisons. They cause protein denaturation and coagulation necrosis, leading to severe gastrointestinal injury and systemic symptoms. Phenol is used as an antiseptic and preservative, while formaldehyde is found in deodorizing tablets and fumigants. Tincture of iodine can cause severe, life-threatening gastrointestinal injury. Concentrated hydrogen peroxide greater than 30% can cause gastrointestinal burn injuries and gas emboli formation. Zinc chloride and mercuric chloride, despite having near physiologic pH, possess very high titratable acid/alkaline reserve, indicating significant tissue damage potential. These are found in soldering flux and preservatives, respectively, and can cause severe systemic toxicity in addition to local caustic effects. Button batteries were once a concern for caustic leakage from their alkaline contents, sodium hydroxide or potassium hydroxide. However, newer generations are more commonly associated with pressure necrosis or electrical injury rather than chemical burns, though caustic injury due to leakage is still possible. Miscellaneous sources of caustic exposure include alkali powder in airbags, which can cause ocular burns, and cement, which is alkaline and causes topical burns. Perfume unintentionally sprayed in eyes can also be caustic. The diverse origins and physicochemical properties of caustic agents necessitate a comprehensive understanding for accurate diagnosis, timely intervention, and effective management of caustic ingestions. Acids and alkalis exert their damaging effects through different cellular mechanisms. Alkaline contact, caused by alkalis that are proton acceptors, forms hydroxide ions. This leads to liquefaction necrosis, a process involving fat saponification and protein disruption. This allows for deeper penetration of the alkaline substance into the tissue, potentially leading to transmural damage and perforation. Alkalis are often colorless and odorless and may not cause immediate pain, which can result in larger ingestions and more extensive burns. The esophagus is particularly vulnerable to alkaline damage, especially at narrow portions where pooling can occur. Gastric and intestinal necrosis can also result from alkaline ingestion. Acidic compounds, which are proton donors that release hydrogen ions, primarily cause coagulation necrosis. This occurs by desiccating epithelial cells and denaturing proteins. This process forms a thick eschar or coagulum that theoretically limits further penetration into deeper tissues. Acids often have a strong odor and cause immediate pain, which typically limits the quantity ingested. While traditionally thought to cause less esophageal injury due to rapid transit to the stomach, severe esophageal and laryngeal injury can still occur, especially with intentional ingestions. Acid ingestion frequently results in equal esophageal and gastric mucosal injury. Pylorospasm can lead to gastric pooling, outlet obstruction, and perforation. Acids can also be systemically absorbed, causing metabolic acidosis and damage to organs such as the spleen, liver, biliary tract, pancreas, and kidneys. Despite these mechanistic differences, strong acids and alkalis are equally capable of causing severe, full-thickness injury to the gastrointestinal tract in clinical practice. Caustic damage to tissues progresses through distinct phases, beginning with initial necrosis and inflammation in the first 24 hours. During this period, immediate cell death, bacterial invasion, and infiltration by polymorphonuclear leukocytes occur, with vascular thrombosis increasing the damage. The next phase, sloughing and low tensile strength, takes place from day 2 to day 14. Superficial layers of injured tissue typically begin to slough off within 2 to 5 days. The healing tissue has low tensile strength for up to 3 weeks, significantly increasing the risk of delayed perforation. Wound strength is weakest between day 5 and day 14. Following this, granulation tissue formation and re-epithelialization occur from week 1 to several months. Granulation tissue forms, collagen is deposited, and re-epithelialization happens in the burned area. This progressive remodeling narrows the esophageal lumen. Finally, stricture formation can manifest from weeks to years after the injury. Esophageal strictures, formed from the contraction of scar tissue, can become apparent from 2 to 8 weeks post-ingestion. The risk of stricture formation correlates with the depth and circumference of the initial injury. Grade 1 injuries, characterized by edema and hyperemia, do not progress to strictures. Grade 2A injuries, which are non-circumferential superficial ulcers, rarely form strictures, while grade 2B injuries described as circumferential deep ulcers develop strictures in up to 75% of cases. Grade 3 injuries, involving transmural involvement with deep necrosis, result in strictures in up to 90% of cases. The complex interplay of these pathophysiological factors necessitates a comprehensive and multidisciplinary approach to the diagnosis and management of caustic ingestions, prioritizing immediate stabilization and long-term surveillance for debilitating sequelae. In the context of caustic ingestions, a comprehensive understanding of the clinical presentation is paramount for prompt diagnosis, triage, and management, as the immediate and delayed manifestations can vary widely from asymptomatic to life-threatening emergencies. Upon direct contact with mucosal surfaces, caustic substances cause severe pain in the lips, mouth, tongue, and oropharynx. This acute irritation is often the first indicator of exposure. The severity of pain, however, is not always indicative of the extent of internal damage. Patients may exhibit a range of oropharyngeal and gastrointestinal symptoms. Oral pain, painful swallowing, and difficulty swallowing are common. Difficulty swallowing typically subsides within 3 to 4 days. Drooling and hypersalivation are frequently observed due to pain and difficulty clearing secretions. Vomiting and nausea are also common, with hematemesis indicating potential blood vessel erosion. Abdominal pain is a significant symptom, and if accompanied by fever and tachycardia, it may suggest a severe injury. Airway compromise is an emergent concern occurring from direct inhalation or aspiration of vomitus. Manifestations include hoarseness, stridor, and respiratory distress. Laryngeal edema can develop rapidly within minutes to hours. Epiglottitis, laryngeal edema and ulceration pneumonitis, and impaired gas exchange may result from injury. Tachypnea or hyperpnea may occur due to direct injury or as a compensatory response to metabolic acidosis. Tracheal necrosis is noted as one of the most frequent causes of death after caustic ingestion. Caustic splashes or spills can cause pain, burns, and ulceration of the eyes and skin. For example, alkali powder in airbags can cause ocular burns, and cement can cause topical burns. Some caustics, in addition to local tissue destruction, can cause systemic toxicity. For instance, hydrofluoric acid can lead to life-threatening hypocalcemia and hypomagnesemia due to fluoride ion binding with cations. Ingestion of phenol can cause dysrhythmias, hypotension, seizures, and coma. Formaldehyde metabolism can lead to acidosis. Zinc chloride and mercuric chloride can cause severe systemic cationic metal injury in addition to local effects. Metabolic acidosis and coagulation derangements are ominous signs of severe caustic injury. Esophageal perforation can lead to mediastinitis, while stomach or bowel perforation can lead to peritonitis. Peritoneal signs like abdominal tenderness and rigidity are often late findings. Mediastinitis may present with nonspecific signs like tachycardia and fever, and occasionally a systolic precordial crunching sound Hammond sign on auscultation. Clinicians face a critical challenge because the severity of a caustic injury is often not immediately evident and initial physical findings can be misleading. The absence of clinical signs and symptoms does not exclude severe internal injuries. Many patients may appear clinically well with normal vital signs and a non-tender abdomen, yet have severe gastrointestinal tract injury. Visible burns to the face, lips, or oral cavity are not always clinically reliable predictors of more distal injury. Esophageal injury can be present in more than 1/3 of children without visible oropharyngeal lesions. Conversely, oropharyngeal burns alone do not definitively predict distal injury. Similarly, the presence or absence of abdominal pain or tenderness is a poor predictor of gastrointestinal injury. While some studies suggest combinations of symptoms, e.g., vomiting, drooling, stridor, can predict more severe injury in children, others emphasize that no single symptom or combination can identify all patients with esophageal injury. This variability may depend on the patient population, pediatric versus adult, type of caustic, and circumstances, intentional versus unintentional. A thorough and timely diagnosis and evaluation are paramount to predict patient outcomes, guide interventions, and prevent severe morbidity and mortality. The heterogeneous nature of caustic substances, coupled with varied patient circumstances and clinical presentations, makes this a complex and often daunting task for clinicians. The diagnostic process begins with a comprehensive history and physical examination, although clinicians must be aware that initial findings can be unreliable in predicting the full extent of internal injury. When taking a history, key details to elicit include the exact type of agent, for example, acid, alkali, or other caustic, its concentration, the volume ingested, and the time of ingestion. It is crucial to determine the intent of ingestion, accidental versus intentional, as intentional ingestions, typically by adults, often involve larger volumes and higher concentrations, leading to a greater likelihood of serious injury. Accidental ingestions are more common in children and the elderly, often involving household cleaners. Co-ingestants such as alcohol should also be considered, as they can mask symptoms or alter mental status. The physical examination should focus on the oral cavity, pharynx, supraglottic area, airway, and gastrointestinal tract, while visible burns to the face, lips, and oral cavity may be present. Their absence does not reliably rule out more distal esophageal or gastric injury. Similarly, their presence does not guarantee visceral burns. Signs of upper airway injury, such as hoarseness, stridor, dysphonia, wheezing, coughing, respiratory distress, and drooling, are highly predictive of significant lesions and represent true emergencies due to the risk of rapid edema and airway compromise. Common gastrointestinal symptoms include oral pain, abdominal pain, vomiting, and dysphagia/odynophagia. Abdominal pain or tenderness alone is a poor predictor of gastrointestinal injury, as less than half of patients with esophageal or gastric injuries diagnosed by endoscopy experience these symptoms. Peritoneal signs like abdominal tenderness and rigidity suggest hollow viscous perforation, but are often late findings. Systemic toxicity, hypovolemic shock, hemodynamic instability, hypotension, tachycardia, fever, and metabolic acidosis are ominous signs, often indicating severe injury, extensive tissue necrosis, or perforation. Laboratory assessment has limited utility in diagnosing the exact extent of caustic injury, but is crucial for evaluating systemic toxicity, hemorrhage, and overall patient status. Initially, recommended studies include a complete blood count, which may show neutrophilia or falsely elevated hemoglobin/hematocrit from dehydration. Coagulation studies, such as prothrombin time and partial thromboplastin time, can be elevated in correlation with severe injury. A complete metabolic profile is important for assessing electrolyte imbalances, renal function, and liver function. Additionally, an arterial or venous blood gas with lactate should be obtained. Metabolic acidosis, indicated by acidemia and hyperlactatemia, can signify significant tissue injury or direct acid absorption. Hydrochloric acid ingestion may cause a non-anion gap metabolic acidosis, while other acids like sulfuric acid can lead to an elevated anion gap metabolic acidosis. Alkalis typically cause lactic acidosis due to tissue necrosis rather than systemic absorption. For specific toxin exposures, immediate cardiac monitoring for QTc prolongation and assessment of serum calcium, potassium, and magnesium levels are critical in hydrofluoric acid exposures due to the risk of severe hypocalcemia. For zinc chloride and mercuric chloride ingestions, prevention of systemic absorption is paramount due to cationic metal injury in addition to local caustic effects. Imaging is crucial for identifying complications, especially perforation, and can either supplement or, in some cases, replace endoscopy. Plain radiography, including chest and abdomen X-rays, provides rapid and useful information during initial management. It can detect pneumomediastinum, pneumoperitoneum, pleural effusion, or subcutaneous air, all of which indicate gastrointestinal tract perforation. However, plain radiographs have low sensitivity for detecting perforations, and their absence does not rule out injury. Computed tomography, CT, scans are significantly more sensitive than plain radiography or ultrasound for detecting hollow viscous perforation and can assess surrounding tissues, not visible through endoscopy. A contrast-enhanced CT of the neck, chest, abdomen, and pelvis is the preferred study when serious injury is suspected. It can reveal evidence of perforation, such as mediastinal or extraluminal air, with high sensitivity. CT can also visualize structures beyond severe burns that endoscopy cannot safely reach. While CT has high specificity, its low sensitivity in predicting stricture formation means it should not replace endoscopy as the primary tool for evaluating upper gastrointestinal injury, but rather serve as a useful adjunct. Some studies propose CT grading systems, such as the Bruzzi et al. Or Ryu et al. Classifications, to predict tissue damage and stricture risk, although no superiority among these systems has been established. CT is particularly recommended if endoscopy is unavailable or contraindicated due to patient instability or suspected perforation. Contrast swallow studies can identify areas of esophageal dysmotility or indicate perforation through dye extravasation. However, they have low sensitivities and carry risks of aspiration and inflammation, which limit their usefulness. Esophagogastroduodenoscopy (EGD) is the gold standard for evaluating injuries from caustic ingestion. It provides direct visualization of the mucosal surface, allowing for diagnosis, grading of injury, and prognostication of stricture formation risk. The ideal window for performing an esophagogastroduodenoscopy is within 12 to 24 hours post-ingestion. Performing the procedure too early, such as less than 12 hours, may underestimate the full extent or depth of tissue injury. Conversely, performing it too late, particularly between 5 to 14 days after ingestion, is more hazardous due to wound softening, which significantly increases the risk of iatrogenic perforation. However, some literature suggests it may be safe up to 96 hours with gentle insufflation. Regarding indications, all patients with intentional ingestions, regardless of symptoms, must undergo endoscopy. Esophagogastroduodenoscopy is also strongly considered in symptomatic patients, especially those with posterior pharyngeal burns, stridor, respiratory distress, chest or abdominal pain, or inability to tolerate oral liquids. For unintentional ingestions in children, if they remain completely asymptomatic and tolerate liquids after a few hours of observation, endoscopy may be deferred. Despite this, some experts still suggest all patients with caustic exposure receive an esophagogastroduodenoscopy, as asymptomatic patients can still have significant injury. The Zarger classification is a widely accepted grading system that categorizes injury based on endoscopic appearance, similar to thermal burns, and correlates with stricture risk. Grade 0 indicates a normal esophagus with no stricture risk. Grade 1 involves mucosal edema and hyperemia, also with no stricture risk. Grade 2A presents with superficial ulcers, whitish membranes, exudates, friability, hemorrhage, and non-circumferential lesions, posing a low or rare stricture risk. Grade 2B involves deep or nearly circumferential ulceration, carrying a high stricture risk of up to 75% and a low perforation risk. In Grade 3A, small scattered areas of necrosis are observed, indicating a high stricture risk and a greater perforation risk than Grade 2B. Grade 3B signifies extensive necrosis, with a high risk of both perforation and strictures. Finally, Grade 4 indicates perforation, which is often fatal. A limitation of endoscopy is its inability to accurately predict the depth of necrosis, such as transmural involvement, which can lead to inappropriate management decisions. In such cases, specifically with Grade 2B or 3 injuries, a computerized tomography scan or surgical exploration may be necessary to visualize remaining structures and assess injury depth. The procedure is contraindicated in patients with known or highly suspected perforation. Endoscopic ultrasound (EUS) is currently under investigation as a diagnostic tool. It may prove useful in determining a patient's prognosis, especially regarding stricture formation, when employed with an appropriate grading system. However, at present, there is insufficient evidence to recommend endoscopic ultrasound as a standard component of the caustic ingestion evaluation protocol. Fiber optic bronchoscopy is a mandatory procedure for patients who are being considered for emergency surgery. Its purpose is to detect any involvement of the tracheobronchial tree. The diagnosis and evaluation of caustic ingestions necessitate a multifaceted approach. This integrates a thorough patient history, a physical examination, targeted laboratory studies, and advanced imaging techniques. While endoscopy remains the cornerstone for assessing internal injury and guiding management, clinicians must remain vigilant for subtle signs of severe injury and utilize all available diagnostic tools, including computed tomography, CT scans, to ensure optimal patient outcomes. In the context of caustic ingestions, management and treatment constitute a critical multidisciplinary endeavor aimed at immediate stabilization, prevention of further injury, and mitigation of long-term complications. The approach is highly individualized, considering the type of agent, concentration, volume, patient's intent, and the evolving clinical presentation. The immediate priority for any patient presenting with a caustic ingestion is securing the airway, breathing, and hemodynamic stability. Airway assessment and protection are crucial. Caustic substances can cause rapid tissue softening and edema of the respiratory mucosa, leading to airway compromise. Signs such as stridor, voice changes, hoarseness, muffling, drooling, or respiratory distress necessitate early and definitive airway management. When intubation is required, it should be performed by the most skilled physician available. Fiber optic nasopharyngoscopy or videolaryngoscopy-assisted intubation is recommended to allow direct visualization and avoid blind intubation attempts, which carry a significant risk of perforation of friable tissues. Surgical airways, such as cricothyrotomy or tracheostomy, are considered a second choice as they may complicate later esophageal reconstruction. While generally controversial for esophageal injury, a single dose of a potent corticosteroid, for example, dexamethasone 10 mg intravenously in adults, 0.6 mg per kilogram up to 10 mg in children, may be considered to mitigate airway edema with minimal risk. Hemodynamic support is also vital. Patients may experience hypovolemic shock due to fluid shifts from the intravascular to the interstitial space or from hemorrhage due to vascular erosion or perforation. Large-bore intravenous access should be established promptly, and intravenous fluid resuscitation, for example, 20 to 40 milliliters per kilogram 0.9% normal saline bolus, initiated. Vasopressors may be needed if hypotension persists despite adequate fluid challenge. Healthcare workers should adhere to universal precautions, including removing contaminated clothing and ensuring appropriate hazardous waste disposal to prevent additional exposure and protect personnel. Many common interventions are generally not indicated and can be hazardous in caustic ingestions, with very specific exceptions. Induced emesis is absolutely contraindicated. This is due to the risk of re-exposing the esophagus, oropharynx, and airway to the caustic agent and increasing intra-abdominal pressure, which raises the risk of perforation. Activated charcoal is contraindicated as it does not adsorb caustics and will obscure endoscopic visualization, interfering with assessment and subsequent management. However, there is an exception for systemic toxicity. For ingestions of zinc chloride or mercuric chloride, which cause severe systemic toxicity beyond local caustic effects, activated charcoal is indicated to prevent systemic absorption. Gentle nasogastric tube aspiration may also be used in these cases. Dilution with water or milk is generally not recommended in clinical practice as significant tissue damage occurs almost immediately upon contact. If used, dilution is only beneficial within the first 5 minutes after ingestion, typically at home, and with small volumes, 1 to 2 cups of water or milk. Forcing fluids is never indicated, especially if the patient has difficulty swallowing or signs of airway compromise. It may be most useful for powdered caustics that prolong contact by adhering to tissues. Neutralization with weak acids or alkalis is contraindicated. Attempts to neutralize the ingested corrosive can cause exothermic reactions, releasing heat and gas, which may worsen the injury and increase intraluminal pressure. Endoscopic findings are graded by the Zarger classification, grade 0 to 3, with 2 further divided into 2A and 2B, which correlates with the risk of stricture formation and prognosis. Endoscopy should be terminated at the level of the most proximal circumferential burn, grade 2B or 3, to avoid iatrogenic perforation. The pharmacological management of caustic ingestion is a complex and often controversial area, with a variety of agents considered for their potential to mitigate injury and prevent long-term complications. The use of corticosteroids in caustic esophageal burns remains a highly debated topic. Historically, widespread prophylactic use was not consistently supported by robust evidence and carried significant risks, including masking signs of infection and increasing the risk of esophageal perforation. It's generally accepted that grade 1 injuries, erythema, and edema do not warrant corticosteroid therapy as they typically heal without complications. Similarly, grade 3 injuries, full-thickness necrosis, often progress to stricture formation regardless of steroid intervention, and the risks associated with corticosteroids in this setting are particularly high. However, a significant body of research points to a potential benefit in a very specific subset of patients, those with grade 2B circumferential esophageal burns. A notable study suggests that high-dose methylprednisolone 1g/1.73 m superscript 2/day for 3 days may reduce stricture formation in this particular group. Grade 2B burns are characterized by deeper ulcerations and exudates, often involving the entire circumference of the esophagus, placing them at a high risk for stricture development. Crucially, these patients also have a relatively low risk of acute perforation, making them the most likely to benefit from the wound softening and anti-inflammatory effects of steroids, and least likely to be harmed. This targeted approach is supported by the opinions of some expert practitioners in the field. Prophylactic antibiotic use in caustic ingestion is generally not indicated in the absence of corticosteroid administration. Antibiotics are reserved for patients with proven esophageal perforation or identified systemic infection. However, the early post-ingestion period can be challenging, as the febrile response to caustic injury can be indistinguishable from that of an emerging infection. Consequently, many patients may receive empiric parenteral antibiotics early in their course due to this diagnostic ambiguity. These agents play a role in reducing gastric acid production, which can minimize further injury to the already compromised esophageal and gastric mucosa. Acid reflux can exacerbate existing caustic burns and potentially contribute to delayed stricture formation. Some studies suggest that the use of omeprazole, a commonly prescribed PPI, may improve the endoscopic grading of esophageal injury. While extensive controlled studies are somewhat lacking, PPIs and H2 antagonists are generally considered reasonable adjunctive therapy due to their well-established safety profile and theoretical benefits in reducing secondary acid-related damage. Sucralfate is a mucosal protective agent that forms a viscous, adherent barrier over ulcerated tissue, potentially promoting healing. Some studies have suggested that sucralfate may possess favorable healing properties and could reduce the incidence of symptomatic strictures following caustic ingestion. However, more robust clinical trials are needed to definitively establish its efficacy and optimal role in this context. Mitomycin C is an antineoplastic antibiotic that, when applied endoscopically, has shown promise in reducing scarring by inducing fibroblast apoptosis. This localized application aims to inhibit the excessive collagen deposition that leads to stricture formation. Studies have demonstrated that mitomycin C can reduce both symptoms and the number of dilations required for caustic-induced strictures, particularly those that are long or refractory to conventional treatment. Despite these encouraging findings, a significant unanswered question remains regarding the long-term risk of malignant transformation due to the potential for DNA damage induced by mitomycin C. This concern necessitates careful consideration and ongoing research before widespread adoption. Surgical consultation is crucial in cases of suspected or confirmed severe injury. Emergency surgery is indicated by several factors. Perforation is a key indicator, often identified by the presence of free air on imaging, with CT scans being highly sensitive for detection. Signs of peritonitis or severe abdominal rigidity suggest hollow viscous perforation or extensive burn extension. Persistent hypotension is a serious finding, often pointing to perforation or significant blood loss. Extensive necrosis, particularly grade 3 burns observed during endoscopy, or on CT, is frequently associated with high mortality rates if not surgically addressed. Additionally, systemic signs such as elevated PT/PTT and acidemia correlate with severe injury that necessitates surgery. The primary goal of surgical intervention is the removal of all necrotic tissue. An exploratory laparotomy is the standard approach, though laparoscopy can be utilized for initial assessment. Procedures can vary widely from the resection of small fragments to extensive operations like esophagogastrectomy, total gastrectomy, or pancreatoduodenectomy, all depending on the extent of the necrosis. Early surgical intervention for extensive necrosis is life-saving and can decrease both morbidity and mortality. Delays in diagnosis significantly contribute to mortality. For patients with significant caustic injuries, nutritional support is crucial for healing and recovery, as they often enter a hypercatabolic state and may be unable to tolerate oral intake. Methods of nutritional support include total parenteral nutrition, gastrostomy, or jejunostomy, which may be necessary, especially for patients with grade 2B or worse injuries. When feasible, enteral feeding via a nasogastric tube, if placed endoscopically under direct visualization, or jejunostomy is generally preferred over parenteral nutrition. Patients who survive the acute phase of severe caustic ingestion require ongoing care to manage delayed complications and monitor for long-term risks. The most common and disabling long-term complication is stricture formation, occurring weeks to months after ingestion. Treatment for strictures includes endoscopic dilation, which is the first-line management, typically starting 3 to 6 weeks post-injury. This involves using progressively larger bougies over guide wires, and multiple sessions are often required. Esophageal stents may also be used to maintain luminal patency and prevent stricture formation, though their efficacy and ideal use remain under investigation due to issues like migration and high recurrence rates. Surgical reconstruction or bypass is considered for strictures resistant to dilation, or in severe cases, using the stomach, jejunum, or colon to restore digestive continuity. This is complex and often associated with morbidity. Patients with significant esophageal burns, grade 2B or 3 injuries, have a substantially increased risk, 1,000-fold, of developing esophageal squamous cell carcinoma, often decades after the initial ingestion, e.g. 40 to 50 years latency. Long-term endoscopic follow-up is recommended for these patients, possibly yearly, to screen for neoplastic changes and obtain biopsies of suspicious lesions, regardless of functional status. Other complications include upper gastrointestinal bleeding, tracheoesophageal fistulas, pulmonary complications, e.g. aspiration pneumonia, small airway obstruction, gastric atony, pseudodiverticula, and gastric outlet obstruction. Pharyngeal strictures and microstomia can also occur, severely impacting deglutition and respiration. For button batteries lodged in the airway or esophagus, expeditious endoscopic removal is required. Gastric or intestinal batteries may be managed with watchful waiting and follow-up radiographs. The primary concern for newer batteries is often electrical injury rather than caustic leakage. Ocular exposures are true ophthalmologic emergencies. Immediate and copious irrigation with saline or water for a minimum of 15 minutes is indicated, followed by ophthalmologist consultation. pH testing of ophthalmic secretions can guide irrigation adequacy. Effective management of caustic ingestions necessitates a multidisciplinary approach. This team often includes emergency care physicians and toxicologists, surgeons, general thoracic and anesthesiologists, gastroenterologists and otolaryngologists, radiologists, nurses, nutritionists for dietary planning and support, and mental health practitioners for psychiatric evaluation and support, especially in intentional ingestions. Smooth coordination among these professionals has been shown to improve patient outcomes. Caustic ingestions present a critical medical concern due to their potential for severe, life-threatening injuries and debilitating long-term consequences. Understanding these caustic agents, also known as corrosives, is vital. They are substances that chemically destroy tissue upon direct contact with mucosal surfaces. These agents are broadly categorized into acids with a pH less than 3, which are proton donors that cause coagulation necrosis, forming a protective eschar. Alkalis with a pH greater than 11 are proton acceptors that cause liquefaction necrosis, allowing deeper tissue penetration. Other caustic agents include phenols, formaldehyde, and concentrated hydrogen peroxide. These substances are commonly found in household and industrial products such as drain cleaners, which are high-concentration alkalis, toilet bowl cleaners, which are strong acids, and laundry detergent pods. The severity of injury depends on factors like concentration, pH, titratable acid, or alkaline reserve, volume, physical state where liquids cause more distal burns and solids more proximal, and duration of contact. The damage caused by caustic substances progresses through several phases. The initial phase involves necrosis and inflammation, occurring within the first 24 hours. This is followed by a period of sloughing and low tensile strength from days 2 to 14, which is a critical time for tissue integrity. Granulation tissue formation then follows the sloughing phase. Finally, stricture formation can develop weeks to years later. Esophageal strictures are the most common long-term complication, and their risk directly correlates with the depth and circumference of the initial injury. For example, Grade 2B and Grade 3 injuries carry a high risk of 75 to 90% for stricture formation. The initial symptoms of caustic ingestion are highly variable and do not reliably predict the severity of internal injury. Patients may experience oral pain, difficulty swallowing, drooling, vomiting, or abdominal pain. Airway compromise, indicated by hoarseness, stridor, or respiratory distress, is an emergent concern due to rapid laryngeal edema. Systemic manifestations can include metabolic acidosis, hypovolemic shock, and signs of perforation such as peritonitis, though peritoneal signs are often late findings. Diagnosis relies on several components. A thorough history should focus on the agent, concentration, volume, and intent of ingestion. A physical examination should prioritize airway assessment. Laboratory studies, including a complete blood count, comprehensive metabolic panel, coagulation profile, and blood gas with lactate, are crucial for assessing systemic impact. Imaging, particularly contrast-enhanced computer tomography scans, is highly sensitive for detecting complications like perforation, evidenced by pneumomediastinum or pneumoperitoneum, and for visualizing structures beyond endoscopic reach. Esophagogastroduodenoscopy remains the gold standard for evaluating internal injury and is ideally performed within 12 to 24 hours post-ingestion. This procedure allows for direct visualization and grading of injury using the Zarger classification, which guides prognosis and management. Performing the esophagogastroduodenoscopy too early can underestimate the injury, while delaying too long increases the risk of iatrogenic perforation. The management of caustic ingestions involves both emergency and long-term approaches. Emergency management prioritizes airway protection, often requiring skilled intubation. Hemodynamic stabilization is crucial for unstable patients. Certain interventions are contraindicated, such as induced emesis, activated charcoal, or neutralization, due to risks of worsening injury or obscuring visualization. Dilution with water or milk has limited utility and is only beneficial within the first 5 minutes. The role of pharmacological interventions is controversial. Corticosteroids may be considered for Grade 2B circumferential esophageal burns to reduce stricture risk, but are not universally indicated. Emergency surgical intervention is imperative for confirmed or suspected perforation, extensive necrosis Grade 3, or persistent hemodynamic instability. Nutritional support is critical for healing and recovery. Long-term management primarily involves treating strictures with endoscopic dilation or surgically for refractory cases. Lifelong surveillance for esophageal squamous cell carcinoma is also necessary, as the risk is significantly increased by 1,000-fold in patients with Grade 2B or 3 injuries. Effective management of caustic ingestions requires a comprehensive, multidisciplinary team approach involving emergency, surgical, gastroenterological, and other specialists.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.